The title of this presentation is Cardiac Morphometric Measurements of Size and Shape in Fetuses with Absent Reversed Umbilical Artery Doppler Blood Flow Wave Patterns. I would like to thank my colleagues, Dr. Edgar Hernandez Andrade and Dr. Roberto Romero of the Perinatology Research Branch of the Eunice Kennedy Shriver National Institute of Child Health and Human Development for their collaboration with this study. Objective: evaluate the end diastolic size and shape of the four-chamber view as well as the size and shape of the right and left ventricles in fetuses with severe growth restriction with absent or reversed diastolic flow of the umbilical artery and compare results from those with perinatal deaths and those who survived the neonatal period. Let's now review the methods used in this study. First, let's discuss speckle tracking analysis. Speckle tracking analysis evaluates movement of the endocardium during a cardiac cycle. Using the right ventricle as an example, the user simply places the cursor at the base of the ventricle, points 1 and 2, and at the apex, point 3. This then activates the software analysis to compute the endocardial borders at end systole and end diastole. Once the yellow lines identify the contour of the endocardium, the user can adjust each point of the contour as needed. What does speckle tracking mean? The endocardium of each ventricle is composed of digital pixels. The image on the left illustrates a portion of the endocardium of the left ventricular septum, which has pixels of various shades of gray in intensity, represented by the green box. These pixels, or speckles, located at different locations along the endocardial border, can be tracked by computer software as the ventricles contract. Let's now do a deep dive and examine what is being done by the software. From these thumbprints of pixels, 24 equidistant points on the lateral wall and 24 points on the septal wall are identified, represented by the red dots on the graphic on the right. For example, point 1 is at the base of the lateral wall and point 24 is located at the apex of the lateral wall. Point 26 is opposite point 24 at the apex of the septal wall, and point 49 is at the base of the septal wall is opposite point 1 of the lateral wall. Data from the locations of these points from each side of the chamber are used for the computations of the width of 24 segments distributed from the base to the apex of the ventricle as well as the length. The 24-segment end diastolic and end systolic widths of the right and left ventricles is a new concept. The graphic on the right illustrates the 24 segments, with segment 1 located at the base, segment 12 located at the midsection of the ventricle, and segment 24 located at the apex. In addition, the length of each chamber can be computed. These end diastolic measurements form the basis for a number of derived measurements that were used in this study to compute the size and shape of the ventricular chambers. In addition to speckle tracking analysis to determine the size and shape of the ventricles, other cardiac measurements were also used. These measurements included measuring the end diastolic length and width of the four-chamber view as well as the area. From these two measurements, the global sphericity index obtained by dividing the length by the width was computed. Any value less than the fifth centile was considered to be associated with a globular-shaped chamber. The size of the four-chamber view was computed from these two diameters as well. In addition, the thickness identified by the green circles of the right and left lateral walls was made at the level of the mid-chamber at end diastole. Let's now review the demographics of the study subjects. The study consisted of 49 fetuses with absent or reversed end diastolic flow of the umbilical artery. Group 1 consisted of 13 fetuses who experienced a perinatal death. Of the 13 deaths, 6 occurred in utero and 7 in the neonatal period. Group 2 consisted of 36 fetuses who survived the neonatal period. The gestational ages for Group 1 was between 21 and 32 weeks, and Group 2, 23 to 32 weeks. Let's now review the statistics that were used in this study. First, Z-score measurements were computed for 49 study subjects. The Z-score was obtained by measuring each cardiac structure from each study fetus, then subtracting the expected mean value from a normal control group of 200 fetuses, and then dividing the value by the standard deviation from the control group. The independent variable used to compute the mean and standard deviation was the ultrasound estimated fetal weight. Once each study fetus's Z-score was computed for each measurement, the number and corresponding percent of fetuses with abnormal Z-score values less than minus 1.65, or the fifth centile, or greater than 1.65 of the 95th centile were tabulated. to determine if there was a significant difference in the number of fetuses with abnormal findings between those who had a perinatal death versus those who survived the neonatal period, Fisher's exact test was used for the analysis. The number of fetuses in each group was converted to a percentage for this presentation. Let's now review the results of measurements that demonstrated no significant differences between fetuses who had a perinatal death and those that survived the neonatal period. Measurements of the four-chamber view demonstrated no significant differences in the number of fetuses who had a perinatal death and those who did not for the area, width, length, and global sphericity index of the four-chamber view. Although not significant, 77% of those who died had an enlarged end-diastolic area of the four-chamber view, and 92% had an increased transverse width. The right and left ventricles demonstrated no significant differences in the number of fetuses who had a perinatal death and those who did not for the right and left end-diastolic length of the ventricles. The right and left ventricles demonstrated no significant differences in the number of fetuses who had a perinatal death and those who did not for the right and left end-diastolic wall thickness. The right and left ventricles demonstrated no significant differences in the number of fetuses who had a perinatal death and those who did not for the right and left end-diastolic transverse widths for all segments of the left ventricle and segments 1 to 16 of the right ventricle. The right to left area ratio demonstrated no significant differences in the number of fetuses who had a perinatal death and those who did not. Let's now review the results of measurements that demonstrated significant differences between fetuses who had a perinatal death and those that survived the neonatal period. The 24-segment transverse widths located at the apex of the left ventricle that were greater than the 95th centile were only present in fetuses with perinatal deaths. The 24-segment transverse widths located at the apex of the right ventricle that were greater than the 95th centile were only present in fetuses who were neonatal survivors. The 24-segment transverse widths located at the left ventricular base and apex and the right ventricular apex that were less than the 5th centile were only present in those who were neonatal survivors. End-diastolic areas of the left and right ventricles less than the 5th centile were only present in fetuses who were neonatal survivors. The 24-segment transverse sphericity index less than the 5th centile, suggesting a more globular-shaped chamber, was only present in neonatal survivors. This was observed for the left ventricle midsection, segments 9 to 16, and the right ventricle base and mid-chambers, segments 1 to 16. Conclusions. The study identified similarities of size and shape of the four-chamber view and ventricles and differences between fetuses who died in utero or the neonatal period and those who did not. 2. The major differences between perinatal deaths and neonatal survivors were as follows. Smaller 24-segment diameters of the right and left ventricles as well as smaller right and left ventricular areas were present in neonatal survivors but not present in those with perinatal deaths. Increased widths of left ventricular segments 17 to 24 were unique to perinatal deaths. Increased widths of left ventricular segments 17 to 24 were unique to perinatal death fetuses, while increased widths of segments 17 to 24 were unique to neonatal survivors. In addition, fetuses with more globular right ventricular transverse segments 1 to 16 may not be at increased risk for perinatal death. Thank you for your thoughtful participation.